So we are looking at care call. What we do is basically taking the journey of our patient through visiting the hospitals of choice. For example, they have come to see Dr. Onsongo at Equity Afya, and then through their diagnosis, we take them through a journey of recovery. I have a problem, let's say I have erectile dysfunction, for example.
Interesting example.
It's
okay.
really, it's a pandemic in Kenya. That's why I have to throw that name. It's really a big problem. Today, the age has gone to an average of 30 years.
Are you
So
serious?
it's really a big
Wow.
problem to the younger population in the society. I will share this, and sometimes it's painful to me that the lady was almost dying. Is an online writer in Kitengela. So the lady comes to us with high pressures. And when we picked up the case, we realized the lady actually was not really hypertensive, but it was the pressures she was handling. And one of the only things that we changed is to tell the lady, kindly try to offload the work you're doing and spend more time also to sleep for 8 hours, 7 to 8 hours. This metabolic syndrome in Kenya, in Africa, the figures are almost what is in the West. We are talking about almost in every family today.
Wow.
Nearly 50% of hospital admissions in today is because of chronic diseases. Every Kenyan is just one diagnosis away from poverty. Like, you just need, in the whole family, you just need one thing.
Welcome to today's episode of Keep It Clutch. We are pleased to be here today with Dr. Onsongo, a seasoned healthcare professional who is helping build the future of AI and healthcare in Kenya. And I am your host, Nzisa Kilu, founder and CEO of Clutch Foundry. And this is Keep It Clutch. So let's dive in. Dr. Onsongo, welcome.
Yes. Thank you.
Glad to have you here.
I'm excited.
Karibu sana.
Asante.
So let's start with something fun. I know a couple of your team members are here. What is it you can tell us, something interesting or quirky about you that we don't know?
I'm a fun person. What I can say that is exciting about me is that currently I'm a great swimmer, but I only learned to swim in third floor when I was barely 29 years old. Yeah, so it's something that I'm happy about.
Oh, good.
Yes.
Yeah, I used to swim in high school. So,
Oh.
and no, in high school, in primary school. So
Oh, that's great. You
it's very
started a long time ago.
It's a long time ago. But
And you are a
once
swimmer
you
today?
finish, yeah, I'm still a swimmer today.
Once a
so
swimmer, always a swimmer.
Once a swimmer, always a swimmer. Karibu,
Yeah,
karibu.
I started late, but
But you've caught up.
Yes.
Okay, good.
That's great.
So, who is Dr. Onsongo? Tell us a little bit about who you are. Why are we here today? Who is Dr. Onsongo?
That's great.
For the audience.
Dr. Onsongo Boniface is a doctor by profession, practicing in Kenya currently under the umbrella, the Equity Afya Group of Medical Facilities. Dr. Onsongo is a passionate doctor in wellness. That's why currently I'm a wellness advocate. So I've ventured a lot into the wellness space industry. That's why I'm here, courtesy of my interest in wellness and trying to solve the far-reaching problems at the society. That is, what can we do to improve the current health sector in Kenya?
Very nice. Yeah. So I think we've talked before, obviously, and we work together, which we'll get into. But both of us have lifestyle and chronic diseases in our families.
Yes.
Can you maybe give us a little bit of background on how, that exposure to health and health concerns within your family has influenced you becoming a doctor? Maybe even as far back as when you were young? Like, how did you become a doctor? When did you decide to become a doctor? Yeah.
This is actually a dream that started way back when I was a young boy back in primary school at grade 7. Traditionally, it was class 7, the former education system in Kenya. So that's the time I lost my mother, and it was really a long journey because in 2006, she succumbed to a condition that she didn't know what she was suffering from. So for more than 10 years, I remember when I was young, every 6 months, we always went to one hospital to another facility in Kenya. Yeah. We didn't manage to afford better healthcare, so we always rotated around my county hospitals back in Nyanza. And what used to happen is that our blood levels were always low. That means anemia. I knew HB when I was even in primary school because my mother was always admitted, and whenever she came back, they were always mentioning that HB was low.
What is HB for those who don't know?
I even at that time could not understand what that meant, okay. But it's basically the hemoglobin levels, which indicate the level of red blood cell in your blood. Okay. But I could not understand why our blood levels were always low. So for more than 10 years, we visited listed one hospital to another facility until a time came that we decided to change the environment. You see, traditionally, when you are sick in the villages of Africa, they start even suspecting things beyond
Witchcraft.
medicine. Yes. So we decided to move from my village and go to Trans Nzoia, Kitale. That meant that we tried to do something different to see whether our outcome will be better. But it was nothing could happen for about 3 years. We stayed there. Then one time at about midnight, she has this vomiting of blood. I have a basin of blood in the house. Then we waited until morning because there were no means
No
of transport.
ambulances, yeah.
There was no nearby facility. We didn't have somebody to call. There was no a number that you can contact to seek medical advice. So in the morning, she was rushed to Kitale Referral Facility. But unfortunately, 3 weeks later, she succumbed. Unfortunately, Zisha, that the condition she suffered from was actually a symptom. The hemoglobin levels being low is not a real problem. The real problem was that she was suffering from what we call leukemia, which is actually cancer of the blood. And we didn't know about that.
And they didn't test?
They didn't test, ideally, because either there were no resources for the facility that she had visited, or we were ignorant on what to seek for.
That's true.
In healthcare, yes.
Do you think that's because at the time we didn't know the markers for leukemia, or do you think it was the particular hospitals and the capabilities because it's not maybe Nairobi, for example, or what do you think was the factor at that time?
I think the factors are multidisciplinary. One of it I can mention is the lack of resources and lack of health information. Okay. But also affordability was a big concern because we didn't have resources to bring her to Nairobi to seek better services. So the markers were there. And I remember the results came actually, the last facility that she was admitted to, they took a sample. So that means the doctor suspected something is wrong for all those years she was suffering from the low HB. But the results came actually weeks later. So I only came to know them later on, years later, that it was actually leukemia. Yes.
Yeah. Sorry to hear that about your mom.
It's okay. So it's a learning experience. But it pushed me to limits that I thought I could not reach. Because that challenged me in grade 6, in grade 7, grade 8, that I said, what can I do to change that narrative? Why was my mother sick for 10 years? Yeah. Why was she always admitted every 6 months in one facility, another facility? Yeah. All those questions kept on lingering in my head. So when I got a chance to advance my studies in high school, even in the university, I always said, there's something I can do. Funny enough, actually, I nobody suspected that I will ever become a doctor because when my mother is dying, I was the last student in class.
Oh, because you had to, it's emotionally...
emotionally challenging, but then it kept me getting the energy to do something different. Yes.
Okay. Yeah, I mean, we get inspiration from the saddest, the deepest, saddest
very
depth.
True, very true.
Sorry to hear that.
Thank you.
So you're in primary, you have this inspiration, you go to high school, then after that you go in the path of becoming a doctor.
Yes.
Maybe tell us a little bit about that. Where did you study? What did you study? And then how did you go into becoming a practicing doctor after that?
So then I finished my studies in high school. Then I joined the Kenyatta University to pursue my course, that is medicine and surgery. Of course, from 2012 to 2018, I graduated as a general practitioner. That means a doctor who basically manages all conditions without specializing. That's the time actually I got interest to try and ask myself, what then happens that we have so many doctors in Kenya? We graduate, many of us, we were a class of more than 100 doctors. Of course, we graduated about 69 or 70 there. But every university that was offering medicine and surgery in Kenya, there were more than 100 doctors graduating annually. Then the question was, is really the problem shortage of doctors? Or we could be having more problems? So when I graduated, I kept on asking myself that question. Then I decided to, even my first year of practice after my internship, I tried to do a program from the Loma Linda University. We had some doctors who came to Kenyatta.
In California?
Yes, but they came to Kenyatta University. They trained us. Very nice professors from there. I remember we had Dr. Avis who came, was at Dean at that time. So they gave us a program on what can you do different to have better outcomes in lifestyle diseases. So it was more of lifestyle management programs. What is wrong with the patient versus what the patient presents to the hospital.
Okay.
So that is why I then decided to do wellness advocacy, which I've done for more than now 5 years
Okay.
in practice. Then lately now I've enrolled into a master's in internal medicine, which mainly, that means I will be becoming a physician soon.
So, but I thought doctors go to school forever. You're still now adding another
Yes, I'm adding
forever.
another forever, but it's only 3 years.
That's good. Good.
Yes.
Congrats. So that's when you kind of decided, I want to be more of, I guess in the US we call it functional doctor.
Yes.
Where they focus on the core symptoms versus the one that I'm presenting at the hospital.
Exactly.
Okay. So give an example of something like that, where what I present to the hospital is actually like an example of what you experienced.
Yes.
In that case.
Exactly.
Yeah.
Now. That's actually now the journey in wellness advocacy, that I'm sick today, I'm having headache. So, of course, sometimes the traditional sector will be prompting somebody to prescribe a painkiller, but then what is prompting me to have that migraine or headache? So we go beyond the symptoms to ask what is wrong in the systems. Some of them are not lab-generated results. Some of them is history taking and trying to have the basic understanding of what the patient is going through in a holistic approach. Then that is where you can come with solutions. Using that model, then we came to realize later on in my career that the problem is not knowing what is wrong. But the other second problem was, after I've known I'm sick, I have this problem, am I motivated to make some choices? And that is actually the journey that we'll be discussing on the future of healthcare in Africa.
Okay. So how does CareCall, which is, I know your company is called CareCall. How does CareCall, first of all, how did you come up with the name CareCall? Because I think it's a pretty clever name, but how did you come up with that name? And maybe tell us a little bit of like, how did you get to now saying we're going to do CareCall, and how that came together? Yeah.
The idea of CareCall, which I'm a co-founder with my colleagues who are co-founders in CareCall, is that we are looking at the aspect of care coordination in a proper aspect. And in care coordination, we are asking the question that, yes, I've been told I have low HB. My mother had low HB for more than 10 years. But what is HB?
Yeah.
What is hemoglobin? Why is it wrong to have a low blood glucose level? Blood sugar levels, for example. So I'm here to look at it this way. In CareCall, the idea of CareCall as a name is that it's a care coordination program whereby we are saying we coordinate the care to an extent to help you understand what is really happening to you versus what is wrong with you. Because sometimes there is this question we have to ask and answer today, that patients, or let's say somebody who's sick, what is wrong with them is different. What's wrong with them is different from what matters to them.
Okay.
Yeah.
Say that again. What is wrong
with the patient is different from what matters to the patient.
What? Okay.
So I can come to you, I'm having a condition. To you as a doctor, you think that you have solved my problems by telling me I have a problem, let's say I have erectile dysfunction, for example.
Interesting example.
Yeah, it's
okay.
really, it's a pandemic in Kenya. That's why I have to throw that name. It's really a big problem. Today, the age has gone to an average of 30 years.
Are you
So
serious?
it's really a big problem to the younger population in the society. So to me, I come to the doctor, I have erectile dysfunction. But the doctor who's serving me knows the problem is not erectile dysfunction. The problem is what is the causes, the anxiety issues, the stress issues, the blood pressure concerns.
Yeah.
So to me, what matters to me is the generator of the erectile dysfunction.
Correct.
But what is wrong with me is not
It's
that.
not that.
So the doctor, many a time, traditionally, we try to solve what is wrong with the patient.
Yeah.
We forget to address what concerns the patient has. So then we lose it there.
So is it like I'm a 30-year-old and I'm getting Viagra? Now I'm from 30 till I'm 80.
You continue
I have to
doing
continue.
Viagra.
And of course it has its side effects and other things.
Yes.
Okay. So
And
instead you want to focus me on
what is causing
the
that.
actual, yeah.
You see, the reason why the health sector is, I kind of say it's not solving the problem, is because doctors then realize that the patient, as long as you address what matters to them, you're okay.
Yeah, okay.
But then is it really the deal? Sometimes it's not the deal.
Okay, so let's stay there for a minute.
Yes.
Why doesn't the doctor feel the responsibility or the push or the drive to go further? Is it insurance? Is it cost? What is it?
There's a cost aspect of that, but there's also an aspect of training, an aspect of infrastructure. I could be a very good doctor trying to have an idea that I can solve society problems, but I'm not enabled. So that's why such solutions going forward looking at what is happening in the West in advanced programs, we can have those infrastructure to support the young doctors who want to pursue some solutions, but they don't have the infrastructure.
Yeah.
That's why it's purely a training issue, a passion issue, but more important, the infrastructure concerns.
So we need to.
Yes.
I mean, I think you saw the Digital Health Act has been passed.
Yes.
Of course, I'm from the US. I mean,
yes.
Kenyan and US.
Yes.
But I've been in the healthcare space in the US for a while too, building digital products. And I always tell people, we didn't just decide to digitize our platforms.
Yes.
We had Affordable Care Act, which was the driving force for providers to be told, hey, if you want to access this funding, you're going to have to get to a minimum viable level of being able to pass digital data. And so in the same token, I hope and believe that that's going to be the catalyzing force
Yes.
for change in healthcare in Kenya as well.
Yes.
Yeah.
That's actually what we are looking forward to.
Oh, yeah, for sure.
It will be transformative to the current practice.
You need a bit of push sometimes to get there.
Yes.
We call it forcing function in technology.
Yes. That's
so I don't know anything about care call. Can you tell me what does care call look like? What is it in action? I know there's some camps. I know there's some monitoring, but can you maybe paint the picture for us of the care call plan?
So the care call agenda is basically, as I said, is a platform where we are trying to solve currently manually, of course. I love to say that, where we don't have digital capabilities.
You have a little bit.
Yes, a little bit of digital capabilities, but we can do better. And sure. I know this is the right solution for us now with you.
Sure.
So we are looking at care call. What we do is basically taking the journey of our patient through visiting the hospitals of choice. For example, they have come to see Dr. Onsongo at Equity Afya, and then through their diagnosis, we take them through a journey of recovery. And our focus at Care Call is on care coordination, and we look at it from this perspective, the wellness front, whereby before I'm sick, because there are actually, I can say there are 4 problems in ailing the health sector in Africa. I don't know in other countries, but one of it is lack of health information.
Okay.
It's one of the biggest problems.
What are the other 3?
The other 3 is affordability of healthcare. I think we have to really look at that. And that's why we have to come with solutions that can try to bring the cost of healthcare downwards. The other problem we are looking at access. I could be sick in Garissa today, in the interiors of Dadaab, in the interiors of Nyanza, in Muranga, in those interiors of the sub-counties.
Yeah.
But then do I have the right doctor to call to give me a right information on what I need to do? So access is a problem.
Yeah.
As much as there are so many solutions that have been there, we still face that as a challenge. So there's we have talked about affordability, lack of information, access. And then I look at it from combining these 3 aspects, then we come to the aspect of coordination of healthcare. And that actually is the biggest problem we have. Yes, I'm sick. I have a sick parent today in the village. For example, my father is hypertensive from 2002, diabetic from 2006. That means more than 2 decades, or let's say more than a decade. But then the question comes that in the village where he is today, who's able to monitor the pressures? Even if he can check the blood pressure today, is the physician in Nairobi, in Kenyatta, are those doctors able to get the data immediately?
Yeah.
The physician has more than 1,000 patients they see in a month.
In Nairobi, before you go to the ones in sub-county.
So how do these physicians in Nairobi get updates from the patients who have gone back to the village? So that's another problem where Care Call is trying to say we can coordinate that care, be an advocate for the patient, have a care coordinator for every patient. Through a care coordinator, a series of care coordinators who can be enabled, of course, going forward, can be able to coordinate that care so that a patient who monitors their blood sugar today, if it's 7, the physician knows that it's 7 without actually calling the physician through that care coordination program. So we look at Care Call trying to solve the aspect of wellness so that the people are healthy, they stay healthy. Those who are sick, to help and modify their risks so that even if they are not really recovering from their chronic diseases, we avoid complications. So we are talking about chronic disease management programs. So for those who are healthy, how do we ensure they stay healthy? For those who are at risk of a particular condition, how do we reverse those risks to prevent the condition? For those who are already sick, how do you ensure they get better healthcare solutions?
And I think it's important for people to know chronic disease doesn't have a cure, right?
Yes.
So once you become chronic, unless maybe you're mildly diabetic.
Yes.
But once you get into the chronic disease path,
Definitely,
that's it.
that is
so
it.
it's either you live a hard life with it,
Yes.
or you live, I guess you're trying to reduce the suffering.
Exactly.
Okay.
And
makes
the
sense.
complications.
And the complications.
Yes.
And the additional
Yes,
what they call
comorbidities.
Comorbidities.
But that is done also. It's good I mentioned that the access being a problem. So we also ensure that CareCall has been doing in partnership with other organizations like Stable Health Foundation, which is a team of many doctors who volunteer. We do a lot of medical camps, outreaches, actually more than 2 in a month.
Okay.
That enables CareCall to reach out to the communities. And that addresses 2 things, affordability and access, because those camps are actually free medical camps.
Free medical camps.
Yes.
Okay.
But then you're able to give them that free service, which is not expensive, then advise them to go to a referral center for continued care.
So just because I know I've talked with you for a bit
Yes,
about
yes.
this, I think it's important for the audience to understand. It sounds like an idea, but it's actually not an idea.
Yes.
It's in action today.
in action, yes.
CareCall has been doing medical camps for how long?
Actually, I can say more than 5 years now.
More than 5 years.
Yes.
So I go to a medical camp.
Yes.
Where is a medical camp held?
The medical camps are in various, depending on, of course, the local partner. For example, recently we partnered with the Royal Media Service, the Citizen TV, and we did a big medical camp seeing more than 5,000 people in
5,000.
Mombasa, Likoni, yes. It was a huge, massive medical camps. Now, these camps are in different counties, but then in Nairobi, we focus on also the corporates. Sometimes it's not only the poor who need our services. We realize that also there are people who can afford healthcare, but they're not getting the right information.
Just avoid the doctor.
So somebody is hypertensive in Nairobi, is a bank manager, but they don't have the information that they can modify some risks and be able to control their pressures in a better way. So these camps are in companies, corporates in Nairobi. We go to churches, we go to schools, we go to open camps in open markets.
Like open markets?
Yes, we do
so
those.
You're covering really the high, middle, low income.
So that we are addressing.
So it's like equitable access.
Exactly.
So I go to the medical camp.
Yes.
You take my vitals.
Yes.
And then what happens after that?
After we take your vitals, we check your blood pressure, blood sugar. We then send you to a nutritionist, which is mandatory for us.
Okay.
Because our medical camps are intentional. We are focusing on what actually can we help you rather than doing a CT scan. Yes, rather than doing a CT scan, we know that if you are your pressures are high, maybe you are obese. So we check your BMI, do what we call body composition analysis. Actually, we are able even to know your metabolic age.
Okay.
Know maybe your what you call visceral fat. Through those basic measurements on the field, which are pretty cheap, then we now send you to a doctor. The doctor is able to evaluate you, give you a report. Sometimes when we are privileged to partner with corporates, we can even do laboratory investigations on site. We check your cholesterol, check your blood sugar, check your creatinine, check your kidney analysis, of course, in partnership with healthcare providers.
Sure.
Currently, we partner with, of course, Equity Affairs, our lead partner. We partner with Pathcare and many other institutions. Now, through this program, we then come up with what we call a coordinated care plan.
Okay.
Which is customized to you in a language that you can understand. For example,
this is I found out that I have a chronic disease.
Yes,
for example.
Yes.
So I never knew I had chronic disease. I went to a medical camp.
Yes.
If I was lucky, my labs came out the same day.
Yes.
And now all of a sudden I found out I have diabetes.
Yes.
Okay.
Then we develop a care plan for you. And in the care plan, it addresses what we have found out from the medical camps and what are the potential solutions to you. These are coordinated. The care plan is coordinated, whereby the physician has given an input, the doctor on site, the nutritionist, sometimes even the counselor, because we have realized many people have also mental issues. So in the care coordination, we address all those. But remember this, in the care camp, in the medical camps, before we even start, we do a self-assessment. We have a tool, we give you the tool, you answer some questions. It's called a self-risk assessment tool. That tool is actually the ones that can guide us to know where to focus on.
Okay.
So that those people will now need a full mental assessment, burnout assessment, maybe they have work burnout, which is affecting their blood pressures, and that will guide us in the approach we use in the care plan that we develop. So after we have developed the care plan, then if you are supposed to go to a referral facilities for continued care, we do those referrals with our partnering facilities. Then we go back to you now. Once you have gone to the referral centers, if you are diabetic, the problems actually, our solutions start there.
Okay.
I'm diabetic.
So
I've
now
seen the best
my care
physician in
call
Nairobi.
plan
Yes.
starts there.
Exactly.
So it's a personalized plan to me
Yes.
for my specific conditions and
Exactly.
my lifestyle problems and everything else going on.
Yes.
Okay.
And you are assigned a care coordinator.
You assign a care coordinator.
That's actually what has been missing for so long. Because if I have a care coordinator, it's like my lawyer.
Yeah.
You see, you go to Nairobi, you say, I will call my lawyer.
Yeah.
So currently, because we cannot, everybody in Kenya cannot have a
afford
doctor.
a lawyer or a doctor.
Yes.
Yeah.
So what we do, we assign you a care coordinator. These are people who are well trained in understanding what you have and how to link you through the next provider or through the nearest provider. So I'm diabetic from a medical camp. I've seen a doctor who has given me 3 drugs to use in a month. The problem was this, Zinsha, I say my father is a diabetic. I'm sorry that a time came that he got complications.
Yeah.
He went to a facility and the doctor tells him that we're actually going to amputate your leg. It was so painful. And I remember he called me and even wanted to fight the doctor.
Oh, yeah, you're not taking my leg.
You are not taking my leg. And
that's why people stay away from the doctor, because they are scared of these things.
From that time, he said he will never go to the hospital. He went, did some kind of herbals, all these, but it even complicated. By the time I brought him to Nairobi, the kidney was getting affected. Now look at how powerful care coordination works. If this person had an advocate, before the leg got that wound, before the kidney was involved, I came to realize it's because he didn't know that the drugs he was using, the dosages had reached that time that they were not working. Because of obviously the risks were increasing.
Okay.
I'd lost my grandmother a few months at that time. So that is a mother stress. All those things complicated. So what was missing is somebody on a monthly basis who's your advocate, looking at your data that you give them on a weekly basis. Of course, unfortunately, we were doing them manually. They had to call my father. And
so you were doing on WhatsApp?
Yes.
At the time,
WhatsApp.
They would send WhatsApp data every day?
140 today, yes.
Okay.
Tomorrow my blood pressure is 120, my sugars are this. The care coordinator actually means that he can actually tell him, oh, you took mango today and your sugar is 10. Tomorrow you took a melon and your sugar is 17. Is it possible that we can ask your nutritionist to question the watermelon? You see the nutrition, then we'll ask my dad, you took excess watermelon, why?
Oh, okay.
So it means next week he won't take a watermelon, half a melon.
Lifestyle tweaking.
And shockingly, within 3 months, the sugars were so stable. To an extent, even the physician dropped one of the medication. That's how powerful. The leg is okay now. The wound dried up. The kidney is perfect.
Wow.
Somebody who was ending up to kidney failure, possibly for dialysis soon, is now okay. But looking back, and I have people in my village, including my uncle, died in dialysis because that program was not there.
Yeah.
So that is how we are saying we can do something. But even something better can be done.
but
So that we stop doing the WhatsApp.
Isn't it like more timely?
Yes.
So as you know, my dad also has chronic disease.
Actually, you told me about it.
Every morning he'll write on his book. And I remember asking him once, I said, you write in your book every day diligently.
Yes.
But you see your doctor every 3 months. You see your nutritionist every 3 months.
Yes.
And the question I've been asking people is, let me ask you the question I've asked.
Yes.
Do you know what you ate last week?
Sometimes they don't even have records.
How can you even remember? So the nutritionist is asking you to estimate what you've been eating. You're giving them
lies.
Lies. It's all lies. I eat cabbage, I eat skuma, I eat this. You're forgetting all the things in between. And I remember thinking like, the doctor will see him in 1 hour, for 1 hour appointment every 3 months. How much of that data is he looking at to make sense of it? It's a lot of numbers. 3 months worth of numbers is a lot of numbers.
It's a lot of numbers.
Even there's probably some metrics around how many numbers a human being can compute. And then the nutritionist, of course, again, you're giving lies to the nutritionist. not like you want to lie, but you don't want to get in trouble. So you're going to give the best foot forward. And I kept wondering what if someone had an intervention issue in between? What happens? Which is what exactly you're saying with your dad.
Yes.
So Care Call, what I'm hearing from you is Care Call gives more frequent updates to your medical team to be able to make any adjustments or intervene.
In a simple language that the patient can understand, and the provider will get the right information when the patient is going to visit the hospital the next visit.
So then we're just going to stay here just a little bit longer, then we move on.
Yes.
So when the Care Call team gets my numbers and I have a problem, what happens today?
So today, for example, you have a blood sugar of 5 and you are diabetic. So the care call has gotten that feedback via WhatsApp. Currently, we are using the WhatsApp platform, and
Okay.
some people, we have some Google links and some Airtable links. They
Okay.
can actually use a link to share that data immediately, and it reflects in an Excel format. Then, if the figures are high, then we have done some, I can call them local automations, where we can know who has high sugars. It can give an alert basically in an email of our care coordinator. So that we say patient X in Tharaka Nithi today, the sugars are above 11. So then that means we need that person to see the physician today. Why should we wait for the next clinic in 3 months and the sugars are above 10? Because as we are rightly saying, and I have to say this passionately, you come to Dr. Onsongo after 3 months, your sugars, when I gave you the drug, they were okay for 1 week. Then they started getting a bit on the borderline for 3 weeks. So you come to me, you have been having a borderline figure of 10, 11, 12, 13. By the time you go to see Dr. Onsongo, already your organs are damaged. Your eyes can no longer see clearly.
Because you were too long in that
phase.
In that phase of.
But what if in day 11, when I released you from my clinic, I'm able to know your values.
Yeah.
I can even tell you, come next week. But that is where affordability comes in. The patient does not want to go to the doctor every month. It's pretty expensive to see a physician. But what if the physician could have just called to say, your sugar is 11, I gave you the best drug, can you check on your diet, please? Can you check on the ugali you are eating on SAP every 8 p.m. and change that ugali to take it in the morning? A simple dynamic change on lifestyle. Can you exercise? Can you sleep for 8 hours? And I will share this, and sometimes it's painful to me that the lady was almost dying. He's an online writer in Kitengela. So the lady comes to us with high pressures. Every month she just says, I want to refill my drugs. I don't want to see a doctor. It was so shocking even to the front office. They were asking this lady, why don't you want to see a doctor? You always say you want to refill your medications. But one day they were able to be convinced by the nurse to see a doctor. And when we picked up the case, we realized the lady actually was not really hypertensive, but it was the pressures she was handling. And one of the only things that we changed is to tell the lady, kindly try to offload the work you're doing and spend more time also to sleep for 8 hours, 7 to 8 hours. And today I can tell you honestly, the lady is okay. The pressures are okay.
Interesting.
A young lady at 24 years.
It's because you're showing me cause and effect.
Exactly. But what if there was no that history, that coordination to ensure that we are advising them to sleep at the right time, drink 8 glasses of water, exercise, eat the right food at the evening meal, take good breakfast, take a light supper, simple dynamics. And that's what counts.
Very interesting. Yes. Very interesting. So let's talk a little bit about framing our relationship.
Yes.
Nia Uzima and Care Call.
Yes.
So Nia Uzima obviously is digital health tools, AI and deep tech and HL7 tools for interoperability and things like that.
Yes.
How do you see that being a benefit to the Care Call, the Care Call infrastructure you've already built today? Where do you see the improvements that can be made by implementing AI, implementing other tech solutions?
That's great. Actually, that's the most exciting journey and what I've been looking forward to in many years of practice in this sector. So in the Nia Uzima Care Call coordination, in the what we have already done in terms of engagement and what we are planning to develop in this relationship, I'm already seeing solutions that have been missing in action. We have been doing more of traditional with some little technology. Of course, even our WhatsApp is a technology.
It's a technology. Airtable is a technology.
Yes. A phone call is telemedicine.
Call is technology. Anything outside of the traditional medicine. So you're already on the way.
But now we are saying that we are using technology that is not the current technology.
Fair.
So in this Nia Uzima Care Call program, we are looking at it to enable, for example, the HL7. I'm not a tech guru, but I'm seeing it I'm seeing the 3 levels of healthcare where we are saying we have management systems. For example, at my facility, I have an hospital management system. When the patient goes to see a physician, I've referred them. I don't have a physician, for example, today in my clinic. I send them to another referral facility. They see a cardiologist in Karen Hospital, and I expect them to come next week to see me. They're using a Karen Hospital to see the cardiologist. The cardiologist gives them some drugs. Next week, they come to my facility. I don't know what they were given in Karen. They have forgotten their drugs at home.
Yeah.
And I have a patient actually who almost complicated because of such defragmentation. So I'm seeing this partnership from that framework that we are looking at it in the 3 levels. We have these providers with their traditional or modern healthcare management system. We have a plan now through Neuzima capability to give us a remote monitoring capability in this partnership. Now, in level 2, we have like the superhighway now. In the superhighway is where you have all this kind of defragmented data connected in a way, and the patient owns the data in their pocket.
Yeah.
So if their pressure in Karen was 149, and their pressure in Equity Afia was 111, and their blood pressure at home is 200. All those records, we should have a way in which we have the data.
Yeah.
So that when they come next week to Karen Hospital, we can know that in X facility, their blood pressure was high. In another facility, it was normal. At home, it was high, so that the doctor can make a combined decision. So in the superhighway, in level, around the level 2 there, in the digital, the framework, is that care can be fragmented.
Okay.
In the 3rd level, I think it's level 1. I'm not a digital guru, but in level 1, we are saying we have now this home of data. It's like a data home. And in this particular segment, AI now comes in. We can have decision made, AI-driven solutions that are able to, so that you can see even 1 million people in one day.
Yeah.
I'm looking at a scenario where in Zisha this year, I can actually manage 1 million hypertensive patients in one count, in 7 counties.
Compared to what? What is your throughput today with your team?
I can say we have about, of course, 1,500 hypertensives, about 900 diabetic patients in our platform.
Yeah.
From populations of more than 20,000 chronic disease patients we see, there are those who we don't onboard in the system willingly.
Yeah.
For those who are on the system, we have actually reversed their conditions. We are about maybe in the margin of thousands, about 3,000.
Wow.
Some are stable and some are not stable.
Yeah.
But now the challenge is that in a day, how many can I call?
How many can you,
How many can I chat via WhatsApp?
Yeah.
So then you realize that one doctor or one nurse, one care coordinator, maximally can maybe follow up 100 patients in a month comfortably.
Yeah.
But what if through now the HL7 framework, we have those 3 levels. Using AI, imagine a scenario where I can sit and have these patients using their, even Mulikamwizi or smartphone, all of them are feeding data to a system without my intervention. I'm just relaxed, and 1 million patients feed their data. AI can actually automate the data transmission and give recommendations which have already been
vetted through
by the physician, the doctor, and the nutritionist. For example, every patient who has a blood pressure above 140, the system says they are advised that they keep on what they're doing and maintain the recommendation of the doctor. But every patient who the pressures are above 140, there's a way the system is made to give them a recommendation that I've been giving them manually through the WhatsApp. That means I can see thousands of patients in a single hour.
So I think
we can reach millions, and care will be affordable.
It will be affordable. So I think what I'm hearing you say is you're able to, those, like you can do some, I guess, for lack of a better word, is some canned responses for some of the conditions, AI and agents. So this is the technologist in the room is going to say, so the agents can intervene for some of those like regular streamlined workflows that you already do today, which are very high touch. And then you can then refocus on actually the cases that you need to personally intersect with. Okay. And then the other thing,
look at this example as you proceed. Let's say one patient is having hypertension because it's the commonest condition currently. And by then there's a crisis. It's a crisis. Metabolic syndrome in Kenya, in Africa. The figures are almost what is in the West. We are talking about almost in every family today.
Wow.
Nearly 50% of hospital admissions in today is because of chronic diseases, and majority of them it's because of hypertension, either diabetes, and of course few cases of cancer. The statistics are worrying to doctors. But let me pick a typical example. Somebody is hypertensive. We are monitoring them. Now, for example, in future, and now in the Neuzima capability and what we are developing, and I'm excited, these hypertensive patients could be having a normal blood pressure for 3 days, but one day they wake up and they feel dizzy, they have this headache, maybe they feel numbness. So through their phone, they can actually say, I'm numb, I have headache. And already the AI-driven solutions can actually give our recommendations without Dr. Onsongo intervention and say, because of those symptoms, kindly check your blood pressure immediately, and the blood pressure maybe will be high. And now the combining those simple information, they get a prompt saying you need to book a doctor immediately. Without them spending 1,000 transport to go to see a physician in Murang'a town, they can then talk to Dr. Onsongo, who's seated in Kitengela or Nairobi, and I tell them, did you take your drug today? And what I've seen is that some of them don't take drugs the right way. So by even them not coming to see me, I can advise them, it means you missed your drug this morning. Can you do it? And we check your blood pressure 2 hours later. And all those symptoms within minutes have already disappeared. That's how powerful these solutions will transform the sector, not only in affordable healthcare, but also quality of care will improve.
Access. I also think sometimes
getting right referrals.
Right referrals. I think sometimes also you're so alone with your disease.
Exactly.
And you've been told it's chronic. And
don't
you're
know
like,
to speak
am I going to die? You're just alone. Where if someone is there just telling you, maybe even a community, I'm thinking we can do a community where people are like walking together. So like my parents found out, for example, that there's a lady on YouTube who does diabetes walks. They're not really diabetes walks, but she started from a diabetes aspect.
Exactly.
So if you look up like diabetic walking or something. So after they eat, they walk on YouTube for half an hour. In the living room. That's something anyone can do before they sleep. You know, small things. But of course you need the awareness, and you need a community. You need people checking in on you. A lot of our patients probably are much older. And you know, old people are very lonely. The young people forget about them and go into the city and work.
So busy,
and they have their own families. So very interesting. I really think the work you're doing is important. So let's switch gears just a little bit. I'm curious, where do they get monitors? Where do they get the equipment at home? What if I don't have technology in my sub-county? Do I need internet? How do we try and solve these problems? Have you thought through these ideas? Because without being able to get the monitoring at home, I can't get the data, then I can't intervene. So
currently not yet there, but we have some solutions that maybe could be there. For example, wearables. We have some companies like that have already come to the Kenyan market. Recently, I was in a launch where one of the company was launching a blood sugar monitoring solution, whereby they have actually a monitoring tool that is put subcutaneous below the skin. Then they can get the records either through their phone or their caregiver. For example, every home has maybe a son who has a smartphone. So through such solutions, when they visit the doctor next time, because that's a 24-hour monitoring tool. So what we can look at is maybe
it's underneath your skin is what you're saying.
So then it monitors the blood sugar in a 24-hour scenario. Those things are actually happening in many European countries. I know maybe in the States also.
Even the States, I know a couple of people.
So those are things we can look at, and how can we get them in an affordable way? Blood sugar monitoring, blood pressure monitoring. But look at now, even assuming we don't have those solutions, but even buying a blood pressure machine, buying a blood sugar machine, you can still buy it, measure, write in a book. And the book disappears when you go to church over the weekend.
True.
So, or maybe things happen. But what if you measure them manually, but using even your Mulika Mwizi, you buy messages and you send them using an SSD code, and those messages can be translated into a digital platform. So that I don't need to worry when I go to see a doctor. I only need to remember I have an account. I have my name, Boniface Onsongo, and my ID number. So when I go to Dr. X in a town, I give them access to something I've been sending values to.
So they can see the metrics there.
The metrics there.
And I think we also, sometimes we don't start things because it feels very difficult. We're like, we don't have monitoring tools. We don't have the money for it. But I can imagine the insurance companies are just as interested in these solutions. Maybe we can influence them. Even counties can have, maybe instead of having cyber cafes, we can have monitoring cafes, right? Where people can go and access monitoring. That would be interesting. Okay, so working with technologists, how has that been? How have you finding it, medics working with technologists?
I'm getting to... it was difficult, I will tell you, in my initial encounter with the engineers, because I kind of suspect they are not trained in their school of training to deal with human, deal with machines, so initially I was getting difficulties, but I'm happy that the Clutch Foundry Group and the Neuzima project that we are working together.
Yeah.
There are people who actually have been exposed to the health industry. These are people who have already developed some health hospital management system, so they have worked with hospital management system. It was easy for me to communicate. But I will say the biggest challenge for me even was to understand even the tech space words, the machine learning, the back end, the front end, various solutions. So those things were really confusing initially, but I'm happy that I've been able to get people like you now who can be able to break them in a language that I can understand as a doctor, and also put the doctor's language in a language that engineers can understand. Yes.
I think there's an assumption that if you're smart in everything.
Exactly.
But like, I'm a technologist, but I don't necessarily know healthcare unless I learn a lot about it. So,
and by that reminds me, from 2019, when 2018, in my first year of practice, I was working in the county government. Actually, that actually prompted me the idea of, is there something we can really do beyond manual, all this, so that we can automate things? I used to see about 120 patients in a single day, sometimes 300 patients in a clinic. Those are hypertensive and diabetic in the county before I quit the county and joined the private sector. So something came to my mind that when you see those patients, and I started looking at solutions. And then I realized engineers, the computer scientists, the tech gurus, they have developed so many solutions which are not addressing the problem. So I remember in 2019, then I approached some people in Nairobi. They had these companies who had come with solutions. But the real problem that the patient wants to address or the doctor is not there. So you get people coming with booking applications, but the problem in Kenya is not booking a doctor.
Yeah.
You realize it's a problem, but it's not the biggest problem. So I know that is actually what I will say. Some engineers, they have ideas of what is the problem. They develop complex solutions, but the real problem is so simple, which sometimes there's now a mismatch between the problem, what the clinicians are trying to address, versus what the engineers are trying to address.
So we over-engineer.
We over-engineer. So I think Neuzima and Caracol solves the problem.
Yeah.
We know what the problem is, and Neuzima has the capabilities on what can be developed so that we match that.
The collaboration is what's important. The real world collaboration with technologies we can't build in a vacuum.
Yes.
So sorry to bring this back around, but I know you talked about your dear mom.
Yes.
I can imagine the financial burden on top of the emotional burden. In your experience from working with these under-resourced communities, what has been your view in terms of, I know Kenya has a lot of problems, Africa has a lot of problems. We're trying to get out of financial holes that some are driven by us, some are driven by other people. But I'm curious for your insights into how you've seen chronic diseases really financially impacting under-resourced communities, especially.
Currently, there's this famous idea that you are actually diagnosis. Just every Kenyan is just one diagnosis away from poverty. Like you just need, in the whole family, you just need one thing. And it takes me back. I was a doctor by day, getting good salary in the county, getting good salary in some private hospitals in Nairobi, big facilities I was working. But I remember when my uncle, became sick. Before my grandmother died, my uncle actually died of diabetes. So I remember we depleted the entire family resources to an extent. A time came that we could not afford a dialysis session. In ICU, going to HDU, dialysis, we are in debts. And I'm a doctor.
And you're a doctor.
There are teachers in the family.
They're looking at you. They're like, doctor, make it happen.
But the one diagnosis, one person sick in a family can actually put a whole family into poverty. The second thing I remember, when my mother was sick, all the lands my father had accrued. My father being a primary school teacher, teachers are very aggressive in purchasing property. So he had bought some lands in the village. All of them were sold to pay the bills. To an extent, when now I'm joining high school and my sisters are also in high school, it became almost impossible for me to start my Form 1 education. Joining university was even more chaotic, but I was lucky that I got a chance to be sponsored through an induction or what we call a work program with Equity.
Okay.
But I'm looking at it through that journey.
Yeah.
It's really a challenge when it comes to healthcare prices,
And just
affordability, and just financial challenges.
Yeah.
So we then look at it that way, and then something has to be done.
Yeah.
Something has to be done, really, because affordability is a big issue, access is a big issue, but we can all agree that using the current models that are there, it's not working.
It's not working.
It's not working completely. I can say it's not working.
Okay. So then who pays? Who pays for this? Or who should we ask to pay for this? Who should we bring into this conversation and tell them, hey, let's sit down and think of how we can make things better?
So there's the who pays and how much they pay.
Okay.
Yes. So the who pays, of course, the patient sometimes has to incur the cost.
Yeah.
The insurance penetration in Kenyan market is actually below 3%.
What?
Yeah, so we are saying
Nairobi can give you a bubble of things.
Yes.
What?
Yes. 3%, less than 3%, 2.7, 2.9. Those are the people who are insured in our industry.
Yeah.
And we are saying the top private facilities in Kenya, in Nairobi, can give you a list without mentioning names. Let's say the top 10 providers, they see more than 70% of their patients who are insured. So we are saying the 3% Kenyans who are insured are almost the ones who are going to the top private facilities in Nairobi in more than 70 to 80% of their clients. What does it mean? The 97% of Kenyans who are not insured, where do they go to?
Public hospital?
Either public hospital or they don't go to hospital.
They don't go at all.
They're sick, they're there at home. So now I'm looking at it this way. The opportunity in that industry means, first, why are insurances only managing 3% of Kenyans? We talk about the disease burdens.
Yeah.
Chronic disease burdens, people fear insuring their communities because it's now becoming a routine that I'm hypertensive in 30 years. By the I will tell you, I got diagnosed of hypertension when I was 27 years old.
Oy.
But it was not really hypertension because I only took medication for 3 months.
Okay.
But if I was not a doctor and maybe I didn't get the right person to advise me,
you'd still be taking it.
I will still be working in 4 hospitals, what we call locum. And that burnout and so much pressures that was coming up, I will still be taking the drug. But because I managed to balance work and life, my pressure is now stable.
Yeah.
So I was 87 kg. I didn't manage my weight at that time. My cholesterol was high. I brought it down. I'm okay. The insurance fear that if they insure people, or especially the chronic disease burden that is increasing, they have to increase the premiums to cover a possible complicating society. So the solution currently, the payer is the insurance, the 3% Kenyans.
Yeah.
The other ones out of pocket, the other ones community, tunachanga. Contributions. People have to come to open WhatsApp forums and all those, then becomes a complicated solutions. So if we can have solutions which are missing, whereby we can have better outcomes, which are proven that it's already working.
True.
Actually, the thousands of diabetic hypertensive we are managing, even the insurances are knocking and saying, this is exciting. As a man in Australia, who a manager, a company manager, who the pressures were high, the complications were already coming in. Today, the pressures are stable. They are not even using the 3 drugs. They are using 1 drug. That means we bring the cost. It's cheaper for the insurance.
Yeah.
That means the insurance can cover more people.
Yeah.
Increase that coverage to even 10%. Have lower premiums.
Yeah.
From maybe 30,000 per month to 1,000 per month.
Yeah.
What if I have 1,000 and I can pay 1,000 per month for my father to be insured?
Yeah.
It means many Kenyans can afford the insurance.
That's
and
true.
I am happy that many insurance providers in Kenya are already getting into that space.
Okay.
But some of them are not able because we in the health sector, you in the tech space, we have not helped the insurances to bring down the cost of healthcare.
Okay.
So I think those are the things that are exciting to me,
on,
that we can actually have an opportunity to have solutions that bring the healthcare cost downwards, have more people insured, and through that, the payer is offloaded the burden.
Yeah.
There are people in Kenya who can afford to pay insurance, but they're not paying. Why? Information. So if we can also have the same solutions coming to educate people, why should I pay for my uncle an insurance cover? And I have money in my account, but I cannot pay because I've not been informed why the insurance is important.
Yeah.
I've not been informed why I need to educate them why they need to comply with the drugs. I need to inform them why they need to see a better doctor to reverse their risks so that the condition is better managed. So I think I said health information is a big problem, affordability is a problem, access is a problem.
Yeah.
So if we have solutions that can tackle those three problems, there's a lot of opportunity.
So there's a lot
there.
of sensitization
Yes,
around
yes,
a
yes.
lot of it too.
Yes.
And I imagine there's this misperception we have.
Yes.
All of us Kenyans have been in fundraising for matangas, right?
Yes.
And I imagine many of the people who are passing away are probably passing away from things could have been health managed.
Yes.
Probably. You hear someone passed away in their sleep.
Yes.
Kumbe, they've been dealing with a chronic disease and we didn't know, right?
Yes.
The amount of money we changa for a funeral.
It's a lot.
What if we pivoted some of that and changad towards care coordination?
Exactly. And a lot of money goes to those groups, mchango. And that person actually, if we had saved his life through solutions in both the tech and the medical side, that money that we are tapping towards contributions will actually insure even 30 more people in the same village, in the same family. And that is what we are saying we has to change.
Yeah, I'm looking forward to doing things a little bit differently. You know, there's a lot of solutions in the US, but I don't think all of them apply in Kenya and in Africa, right?
Yes.
We need a little bit more over and above the technology solutions. We need other things. And also we need to work within, of course, the framework of our culture. Okay, so in closing, I was just curious to get your view. If someone is listening who's either an investor, a health provider, what are your last parting thoughts on coordinating care in Kenya, coordinating care in Africa? What do you think we need help-wise? What do you think can be an enabler? What are your thoughts there?
There's a big opportunity in this particular aspect of the discussion between care coordination, proper health care, and digitally enabled solutions. Now, I'm looking at it this way. As we have rightly said, is that the three problems must be addressed. And the only way they can be addressed is through collaborations between the tech industry and the health industry. So we have some solutions that are already existing, but the reality from our assessment is that we still have solutions that have not been tackled. The care coordination is still not tackled today in our African continent. The issue of AI,
fragmentation,
data defragmentation is still a big problem in our sector, which then has a poor outcome. So in the investment industry, what I will advise is that there's a lot of opportunity in those gaps that have been identified. So look at it this way. Nearly half of all hospital admissions today in Nairobi, in many countries, in many cities, nearly half of all admissions are because of chronic diseases.
Nearly half of all?
Half of all hospital admissions, which also equates to the mortalities. Now, some of those people are able to afford healthcare, but there's little information at the society. There's little capabilities in infrastructure that can streamline the healthcare. There's little resources that can take remote monitors to the village. There's little monitoring applications or even the actual gadgets. And those people can afford. My father can afford. But there's no gadget today that is digitally connected that I can use to send to my father in the village. So I have to use manual solutions. People can afford, but there is no right infrastructure in the system. So we can have this investment both in the digital space and in the health industry space that can be able to connect that healthcare. We'll then see a lot of changes in our network, and then it will also give a return on investment in a big margin. So look at it this way. This week alone, we are doing medical camps, 3 of them. Actually, 2 on Friday and this week, and over the weekend, a big, massive camp. There are 1,000 people we'll be seeing. What if all those people, we enable them, get solutions, and pay for them at a margin that is making the market value? The same happening every week in companies. The insurance is paying our wellness programs. We do many wellness camps every week. Now, the insurance can't pay us. What if we give them better solutions that they can actually add a cost to it and pay for that service, as long as there is a better outcome and reduced costs of healthcare at the end of it. So there's a lot of opportunities there, and we can actually invest our energy in that space.
I also know a lot of friends who
Yes.
are like middle class, maybe
Yes.
upper middle class, who
Yes.
are willing to pay for these things for their parents if they existed.
Yes.
Right? So there's a lot of opportunity. Okay. Do you have any questions or any last comments for me?
I don't have really a question, but I'm looking at it as an exciting journey. We
Yeah.
are looking forward to a Nia Uzima Kiakol continued collaborations. What we have already done in the starting phase is exciting.
Yeah.
We have seen a lot of energy input, solutions that are already working. For example, let me send us a shout out.
Sure.
We recently developed a risk assessment tool in our collaboration near Uzima and Kiakol, and it's working.
Okay,
I'm actually
very
happy
nice.
that we are getting very positive feedback that at the comfort of my home, I can do a diabetic risk assessment and look at what is the probability that my sugars will be elevated, looking at the risks that are assessed. And then I make an informed decision to change some habits to prevent an outcome that could happen in future. Mental assessment tools,
Yeah.
depression tool,
Yeah.
anxiety tool. The most exciting is the holistic tool that is actually now in the end stage of development. In a couple of weeks, we'll be launching those solutions here at the Clutch Foundry and
Yeah.
near Uzima. So such solutions is what we are saying. There is a lot that is happening, and we must do it. We must fix it, and I'm excited that we got the right partners.
Yeah, I'm excited too. And I think from my point of view, yes, we're working on AI and deep tech agent platform for remote monitoring. But the healthcare industry in Kenya has so many other opportunities. So even technologists who are listening, I hope they get inspired to build solutions that can couple with what we have and couple with what is not even there existing to reduce these problems you're talking about, access, connectivity. They also, I know, like, for example, there's Gearbox, which does hardware. Maybe we can collaborate to create, cheaper hardware. We don't always have to wait for other people to bring us solutions from outside. I look forward to a chapter in Kenya where we are the ones solving our own problems. I really look forward to that.
Yes.
Yeah. Thank you so much
Because
for your time
we understand
today.
the problem.
We
have to
understand
fix
the problem. We understand where the shoe pinches.
Yes.
And we know, and we also know what can work and what can't work, right? So you can't bring a remote monitoring solution to Shago. Yet to the village. Yet
Yeah, they
you've
don't
not
have
solved
the
the
machine.
connectivity.
Yes,
You've not
yes,
given
yes.
the machine.
Yes,
There's
yes.
so many problems when you think of an African implementation that you have to consider over and above a Western implementation. Yeah. Thank you so much for your time today.
Thank you so much
Great
for the invite.
conversation.
I'm happy and I'm glad to be joining us, to the team, the production team. Thank you so much.
Thank you so much. Great conversation with Dr. Onsongo and the Care Call team. We encourage you to follow us in our journey. We just started this podcast. It's called Keep It Clutch, and Neo Zima is underneath the umbrella of the Clutch Foundry. Clutch Foundry is an engineering and AI house that's located in Kileleshwa, and we are House 23. We are looking forward to collaborating with a lot of AI startups out here and building solutions that actually solve key challenges in our African ecosystem. And, follow us, like us, Clutch Foundry, one word. We're on LinkedIn, we're on Twitter, is it X? We're on Instagram. So looking forward to hearing from you. Thank you.